Up next, we have our second keynote speaker, Dr. Stacey Armstrong. Dr. Stacey B. Armstrong, Ph.D., is a senior researcher and the associate director of the Center for Psychedelic Drug Research and Education at the Ohio State University College of Social Work. She earned her Ph.D. in psychology at Bowling Green State University after completing a clinical internship at the University of Michigan in Ann Arbor, Michigan. Her clinical fellowship at the Traumatic Stress Center in Akron, Ohio, emphasized the utilization of evidence-based treatments for post-traumatic stress disorder, PTSD, including cognitive processing therapy, CPT, and prolonged exposure, PE. She completed a research fellowship at the Ohio State University evaluating the safety and efficacy of psilocybin in treating treatment-resistant PTSD among U.S. military veterans. Dr. Armstrong is also collaborating on a clinical trial investigating the safety and efficacy of psilocybin in treating depression among lung cancer patients. She is also investigating the patterns of use and acute effects of psychoactive substances in clinical and non-clinical settings, measuring attitudes and beliefs about psychedelic-assisted therapies among mental health professionals, and helping to develop a global registry for opioid use disorder patients who have sought psychedelic therapy in international locations to obtain real-world evidence on the safety and effectiveness of ibogaine as an addictive treatment. She has a particular interest in the subjective effects of psychedelics and their impact on treatment outcomes, as well as how psychedelic-assisted therapies might benefit populations currently excluded from clinical trials. Today, she will be talking about therapy and transition, mental health providers, and the psychedelic frontier. Dr. Armstrong, please take it away.
Thank you so much, Logan, for that introduction. I suppose I could have made it a little bit shorter for us all, but I do appreciate it. And I think I can say at this moment in time, perhaps good morning, good afternoon, and good evening for all of the time zones that might be represented in this space. So I appreciate you and being here. I know that our lives are busy and chaotic, and I know you have lots of places that you could be, so I am grateful to you for being here with me. I'm going to go ahead and share, hopefully, my presentation. Which, from what I can tell, it looks like you're seeing the slides and not the presenter mode. So if for whatever reason I'm wrong.
Yes, that's correct.
Okay, thank you, Logan. I appreciate that. Sometimes it's hard to tell. So I am very excited to be here to talk to you all about something that's come up for me and has become quite a passion of mine, which is, as psychedelic assisted therapies are on the verge of what we anticipate will likely become approved treatments, what is this going to look like in our treatment settings? And how are treatment providers going to kind of fold into this? And there are a lot of challenges and nuances to think about and consider, just given how different these treatments are compared to our gold standard treatments that we have for mental health concerns at this time. So I'll be talking to you about this transition that we're in, our mental health providers, and what that looks like in this kind of psychedelic new age. I want to just share with you a couple of disclosures. I am a board member of Source Research Foundation, and I have a variety of funding sources in my position at the CPDRE. So this is a little bit of a roadmap of where I hope we'll go together in our about an hour that we have, hopefully only about 45 minutes of me actually talking and some time for questions. But I don't think we can have a discussion about what the future of mental health treatment looks like without talking about why we even need mental health treatment in the first place. So I want to talk a bit about a mental health crisis that we're in at the moment, and then spend a little bit of time talking about the efficacy and the data around psychedelic treatment and safety. We'll spend some time talking about the role of mental health professionals and why we need different professionals in this space. And then I'm going to share with you some research that I have been leading with my team at the CPDRE, looking at attitudes and beliefs about psychedelic-assisted therapy among mental health professionals. And then that'll lead us to what does the future of mental health care look like and where we can go from here. But before I jump into all of that great content, I want to share a little bit with you about myself. I've had a very long and winding journey to psychedelic research. It was not at all what I was pursuing when I was in undergrad and whatnot. My journey actually started out in Arizona. So I grew up in kind of the Phoenix area, and I ultimately attended the University of Arizona in Tucson. And it was there that I realized that I was in love with psychology and family studies. When I started, I was 100% certain that I was going to be a medical doctor. And then much to my surprise, I was like, I don't know that I like this. And so I did some exploration, and I really came across psychology and family studies, and I thought, this is where I need to be. So after I graduated, I pursued a PhD in clinical psychology where I focused on children and adolescents. And early in my graduate education, I really began to specialize in the treatment of PTSD, and that started with youth populations. And one reason that I found myself being so passionate about treating pediatric PTSD was because of the potential that existed for children if we can successfully address their concerns, which, if left untreated, can lead to many devastating outcomes throughout childhood. After specializing in psychotherapies for pediatric populations, I wanted to expand a little bit more, so I began treating PTSD among civilians and military veterans. After some time that I provided direct care to families, military veterans, civilians, I came to understand that our treatments were lacking. I recognized that the last significant medical advancement that we had in psychiatry, psychology for mental health concerns was in the late 80s and early 90s with the development of the SSRI. That was a long time ago. So I decided I needed to take a break, and I pursued an academic position. While I was pursuing a tenure track position, I was called to research by the CPDRE to help lead a clinical trial investigating the use of psilocybin for treatment-resistant PTSD among veterans. And ever since I've started this research, I've been considering how these treatments might be beneficial for populations that are not typically included in the clinical trials that are ongoing. These include children and adolescents, but of course, many other diverse populations as well. And I am still passionate about advancing treatment options for pediatric populations to forge a pathway for a healthier adulthood. So, because of all of this, I've actually spent quite a bit of time considering the complex ethics around the rollout of psychedelic-assisted therapy and what that means for mental health care as a field and for the professionals that are going to be leading the charge in this space. So let's actually start off talking about the mental health crisis in the United States. So in the US, mental health concerns among not just adults, but also kids is on the rise. And it's actually disproportionately more so becoming a problem among our youth. Nearly 20% of adults have ever had a diagnosis of depression or anxiety, and nearly 40% of adolescents report depression symptoms. Suicide rates remain one of the leading causes of death among both adults and youth. Nearly half of those who complete suicide have a known mental health condition, and nearly 10% of adolescents report having attempted suicide. I was blown away by this last statistic of 10% of teens reporting having attempted suicide. That is a huge number and indicates to us that we're doing something very wrong. These numbers are not promising, nor are they optimistic. And trends are suggesting that they're getting worse over time, not better. Over the course of the last several decades, since about the 1970s, we have developed hundreds of new psychotherapies for mental health conditions like depression and anxiety. Yet, paradoxically, the rates of these concerns is going up. It's not going down. And the costs of getting treatment for these conditions are also going up. So despite the increase in options for treatment, half of those who need treatment don't receive it. And of those, a third of them don't even have access to it. And this might be because of stigma, but in large part, it's due to a provider shortage. We are busting at the seams with providers who can provide these types of interventions and the huge demand that's increasing of people who need it. The evidence-based treatments we do have, while they do work for some, and I want to make that clear, some people do benefit from our treatments. These treatments often leave many others continuing to struggle. And that's what I experienced when I was working with trauma. I'd sit in sessions week after week after week, doing all the right things. My clients were doing all the right things, and we just weren't seeing much improvement. So often between 50 to 70% of individuals who seek evidence-based treatments for depression and anxiety do not improve. And some even experience worsening of their symptoms. So I probably don't have to tell you this because you probably get it, but why is this a crisis, right? Well, there are many criteria that make a situation a crisis. And there are several factors here that are particularly concerning. First, this is widespread, right? We're seeing this widespread impact with millions affected across all kinds of demographics, age, race, gender, on and on. While we know this is spread across all different demographics, we also know that there are some demographics that are disproportionately affected and who suffer from higher rates of mental health concerns. We're seeing historic rates of mental health concerns in addition to completed suicides, and this is especially true among adolescents. And in addition, many people can't or won't seek help, which is making things worse. And what we know is when people do seek help, our treatments are only helping improve the situation of about 50% of those who receive it, and that's in a best case scenario. And lastly, the impact of mental health concerns profoundly impacts individuals and societies. This includes lost lives to suicide, economic burden of missed work days, and strained institutions and systems as our emergency departments and our primary care physicians are managing the load with fewer mental health providers than is needed. So what do we do about it? We desperately need new novel treatments to address human suffering for adults and for adolescents. And that's due to our lacking treatments. One option is perhaps psychedelic-assisted therapy. But first, what I want to do is briefly talk about psychedelics and what they are and how we think they work. So there are many different types of psychedelic and psychedelic-like substances. And classic psychedelics are one class of psychedelic-like substances. And what makes them a quote-unquote classic psychedelic is that they all affect a very specific receptor in the brain, the 5-HT2A serotonin receptor. This receptor exists in the brain, as I said, but also in the central nervous system. The activity at these sites are associated with a variety of things, including decreased blood flow to certain brain regions. This includes something that was talked about in the last session, which is the default mode network. or a group of brain regions that are associated with kind of those higher order metacognition, thinking, planning, kind of day-to-day operations of being. And it also affects our own sense of self, who we are, what our values are, why we are the way we are. It's also associated, psychedelics and the activation of these receptor sites are also associated with changes in mood and thought, visual and auditory, what we might call hallucinations, and an altered sense of time. So some examples of our classic psychedelics are the most commonly referred to psychedelics, LSD, psilocybin, mescaline, and also DMT, which is a psychedelic compound that's naturally found in many plants and animals, including the poison of the Sonoran Desert Toad. So one way to think about mental health impacts on brain structures is to consider neurons like trees. So trees have branches, and branches can be thought of as structures in the brain in our neuronal cells called dendrites. These are branched extensions of a neuron cell. And the leaves can be considered to be another structure called the synapse, or very specialized junction that exists at the end of a dendrite, where one neuron cell communicates with another. So in a healthy brain, you have this very rich canopy. It has lots of leaves. These leaves are touching each other, and that helps with communication between trees. For many brain disorders, it can look a lot different and might look more like wintertime. The leaves have fallen off and the branches have been pruned back. This makes communication between trees much harder. So psychedelics are believed to be neuroplastogens. These molecules, from what we can tell, seem to rapidly regrow these neuronal arbors, reestablishing the synaptic connectivity. Leaves start to regrow, communication is enhanced, and the brain can kind of communicate with itself between different brain regions and brain areas a lot better and more efficiently. And so with that regrowth of the arbor, that decreases the experience of, from what we assume, I think the jury might still be out a little bit on this, decreases the instance or the experience of things like depression, anxiety, PTSD, so on and so forth. So given what we know about what we think might be happening when people experience a treatment of a psychedelic-assisted therapy, what is the safety and efficacy data showing us? And for many of you, this is probably not going to be new, but I just want to run through very briefly some of the clinical trial data for depression, anxiety, and PTSD, specifically with classic psychedelic psilocybin. So I'd like to start off by discussing 3 separate but related studies investigating psilocybin for major depressive disorder. The first study was a study of adults with treatment-resistant major depressive disorder, and it included 24 adults. Those 24 adults were randomly assigned to 2 separate groups. The first was an immediate treatment group who immediately moved into preparation and dosing. And then there was also a delayed treatment group. So these individuals are kind of put on a wait list in a way, and they received treatment at a point down the road. So this group acted as a control group, right? A group for which we could compare how is one group doing versus the other. How is the group that received the treatment right away doing compared to the group that's still waiting? Now, the data that you're seeing in this graph is everyone combined together after they received their treatment. So we don't have 2 different groups here to show you. What I'm showing you is kind of the collective results here. So researchers reported no serious adverse effects, indicating that the treatment is safe, at least for treatment-resistant major depressive disorder. And participants experienced a significant and robust decrease in depressive symptoms. So we can see here on the left, we see kind of depression scores. It's measured using an assessment tool called the Gridham-D. That's why we have that over there on that axis. And scores were about a 23. And we can see that by the time everyone received their first dose of psilocybin, their scores decreased substantially. So scores on average for all 24 participants were somewhere around perhaps an 8. And we can see that held through the second dosing session that they received. So it stayed about an 8, perhaps maybe went up to a 9. So this is the second study included, the second study here included the same 24 adults from the previous study that I just talked about. So this study was unique in the sense that it followed participants from the original study out 24 months, so a year, past their second psilocybin session. Again, because this was the same group of individuals, there were no serious adverse events that were reported, and there were no new adverse events reported either. And participants reported a durable and sustained reduction in depression 12 months after they received their second psilocybin session. So you can see this is maintained through 12 months. And the third study that I want to share with you is a study that included the same 24 participants from the original study. And this is under review, so it's not published yet, but I want to share it with you. It's a study that we worked with the Hopkins team on at the CPDRE. And what we did is we recontacted the same 24 individuals who participated in the original study, and we wanted to see how they were doing. About the average age of or time of years that it had been since they participated in their second psilocybin session was 5 years. So again, participants reported significant and sustained reductions in depression 5 years after treatment. And what was interesting is we also asked them, we had an interview with all of them as well, and we asked them questions about how they were doing and what their thoughts were about how things have gone. And they said really interesting things about their experience, like they had very lasting positive changes in their mindset, in their emotional health, and in their relationships. And they also experienced enhanced empathy, self-acceptance, and improved in their interpersonal relationships. So what about anxiety? 2 studies here that I just want to touch on briefly to show psilocybin as a treatment for anxiety. Participants in this study were adults with cancer-related depression and anxiety. They enrolled 51 individuals. There were 2 groups for this study, a low versus high dose of psilocybin. And the low dose was so low that it acted basically as the control condition or the comparison group. And they did a crossover study design. So after the first dose, the conditions crossed over such that the low dose condition, or the people in the low dose condition, got the high dose, and the high dose got the low dose. So by the post-2 time point, which you can see on the graph here, when all participants had received the high dose of psilocybin, there were large and sustained decreases in anxiety. And then this is a similar study, slightly different, also for cancer-related depression and anxiety. They enrolled 29 individuals for this study, 2 groups. They compared psilocybin to niacin. Niacin is a vitamin B, and it's commonly been used in psychedelic studies as a placebo condition. And the study, again, was structured with a crossover design with niacin as a placebo. After the first dose, the conditions crossed over such that those in the niacin condition got psilocybin and those in the psilocybin condition got niacin. So by the post-2 time point, again, when all participants had received psilocybin, there were large and sustained decreases in anxiety. And here, the purple is the psilocybin condition and the blue is the niacin. And these are some preliminary results from our trial at Ohio State University looking at the efficacy of psilocybin for treatment-resistant post-traumatic stress disorder among veterans. This is a safety and efficacy trial, and so it's we have very small enrollment numbers, and we're also kind of looking. It's open label, so everyone got psilocybin. We enrolled 12 people as our total number, and the analyses here include 9 of them. So again, open label. All of our 12 participants received psilocybin. 9 of them, again, included here. We can see that when we're measuring PTSD severity, you can see that over here using the CAPS assessment, which is a specific kind of PTSD assessment. But you can see the scores on the CAPS assessment were very high. On average, they were 41. That signifies that individuals are experiencing severe and functionally impairing PTSD symptoms at baseline. And then we can see at 1 month follow-up, scores had decreased significantly. In fact, they decreased by 28 points on average, with an average score of 13, indicating a clinically meaningful response. And then by 6 months follow-up, their scores were 4. That's below threshold for a PTSD diagnosis, suggesting that PTSD is in remission. We were looking at safety, so we observed really no serious adverse effects. We had some mild adverse effects like headaches, and we saw no new instances or worsening of suicidal ideation. So overall, we're seeing significant and robust improvements in PTSD symptoms from baseline all the way through 6 months follow-up. So we're seeing all this really positive information and data coming out of these clinical trials. And there was kind of the experience of MDMA-assisted therapy and approval with FDA, and that didn't happen. But basically, FDA said, well, we want more data. We're not going to say no to this is never going to happen. We want researchers to continue to do research, and we want to see more data. And once we see more data, we'll reassess. And so what we're anticipating is that once we're able to provide FDA with more data, whether that's for MDMA-assisted therapy for PTSD, or whether it's for psilocybin for depression or psilocybin for PTSD, these treatments are coming. And so what does that mean, and what role is there for mental health providers? So psychedelic assisted therapy is inherently interdisciplinary, and it includes elements from a lot of different fields, including psychology, psychiatry, neuroscience, pharmacology, spiritual care, social work, counseling, nursing, on and on and on. And that's because this treatment is complex and it's multifaceted, because psychedelic experiences are complex and multifaceted. So therefore, the therapeutic process that's necessary before and after treatment is likely going to require providers from all different disciplines. So we actually have a real opportunity here, at least I see it as being a real opportunity to really change the landscape of mental health care. What we know from the beginning of this talk is that what we're doing with mental health care isn't working. Things are getting worse. So we need to overhaul our space. And psychedelic assisted therapy might be what we need to do that overhauling. So who are mental health providers, and what is their potential role going to be in psychedelic assisted therapy? Well, we need licensed mental health care providers, social workers, psychologists, counselors, marriage and family therapists. We anticipate that they're going to be involved in preparing clients or patients for their dosing session, being involved in the dosing session, and also helping with integration. And these individuals will need specialized psychedelic assisted therapy training, perhaps credentialing. We also need prescribers. So this is not, it's a unique treatment because it's not just a therapeutic intervention in the sense that it's psychotherapy. There's also a medication component that goes hand in hand with it. And when there's medication involved, we need prescribers to be involved. This includes psychiatrists, physicians, nurse practitioners, physician's assistants. These individuals will be involved in the sense at least anticipated by doing medical evaluations to assess risk, prescribe psychedelics, monitor drug interactions, and perhaps drug contraindications or health contraindications. Nurses are also going to be involved in this treatment. These are individuals like registered nurses or nurse practitioners. We anticipate that they'll be involved to support physical safety during dosing sessions, to monitor vitals, to monitor medical issues, and prescribe and administer the psychedelic substance. Pharmacists also will be involved, monitoring potential drug interactions, will likely be within their scope of work, and also providing medical education when that's needed, or medication, not medical, sorry. And then peer support. So we see peer support specialists show up in other types of treatments. Peer support specialists will likely be very helpful in this space as well. And we anticipate that these individuals will support our clients and patients before and after treatment, and also support harm reduction efforts. So why does interdisciplinarity matter? Why would we even want to seek that? Psychedelic experiences can be profoundly psychological, emotional, physical, spiritual, sometimes separate, sometimes all at once, and that can be quite intense. So the interdisciplinary model actually ensures safety, right? Not just physical safety, but psychological safety as well. We know that it's relatively common for individuals to have a challenging psychedelic experience that's emotionally challenging or cognitively challenging, or sometimes it's physically challenging, or sometimes it's both. But medical providers are needed to ensure physical safety, while we have our mental health therapists there to ensure psychological safety. This allows us, right, to provide these checks and balances in other situations as well when somebody is in a vulnerable state. So we know that there have been instances where people have been abused in situations when they've been in vulnerable states in psychedelic treatment capacities. And so when we have a interdisciplinary team of providers all showing up to treat the same individual, it allows us to provide checks and balances of all of the entire treatment team to ensure that we're treating people with respect, and also ensuring that they're going to be safe, not only from kind of their psychedelic experience, but also from the potential harms that can come from being in a vulnerable state. Effectiveness and efficacy can be benefited from this interdisciplinary framework. It allows us to create a balanced and wrap around providing team to support outcomes and successes, right? So when we have social workers involved who are able to kind of help after the fact, or to engage in policy change and do advocacy, all of those things are helpful in these kind of like wrap around treatment, holistic and supportive environments that are going to lead to more effective outcomes than the traditional models that we have, which is here's a medication, go take it, you should get better, and if you don't, come see me in 3 months. It also can help with meaning making. Meaning making can show up in a lot of different ways in a psychedelic experience. That can be through kind of processing trauma. It could be through a mystical experience, having a very intense somatic experience, an existential experience, cultural experience. All of those different types of things can show up either by themselves or in combination with one another to within a psychedelic experience, and that calls for very diverse therapeutic expertise. So we need a diverse team to be able to show up with somebody in their meaning making. And then also to offer culturally congruent care, to reduce barriers for marginalized populations, and to push for policy change, really all in the spirit of equity and access. So yes, it's great. Let's get everyone involved. Let's have them all show up, all with the same kind of like goal and push to, support individuals and reduce this crisis that we have. I think what we need to do first, right, is look at what do mental health providers actually believe about this treatment. It's new. They haven't done it before. And so I'm sure they have thoughts. Why would it even be important for us to assess attitudes and beliefs? We actually have to do this first and foremost so we can start to explore the landscape of our mental health providers. And this is important for a number of reasons. First, mental health care is evolving. It has been even before psychedelics showed up on the scene, but psychedelics, I think, are really going to change things quite a bit for our providers. It's showing up as a promising intervention, yet its integration into mainstream healthcare really relies on provider acceptance. And so we need to understand what providers even think about these treatments so we can help them get to a place where they can adopt these treatments and see how they might work within their practice. We know that provider attitudes shape access. So professional beliefs influence the recommendations that they give, the referrals that they make, whether or not they themselves provide or participate in psychedelic-assisted therapy, and that will directly impact patient access and outcomes. It will also help us bridge the gap. There is a huge disconnect between scientific support and provider readiness. Understanding attitudes can help us identify what barriers might exist and how we can bridge this gap between readiness and science. Things like stigma and misconceptions absolutely play a role even among our mental health providers. Lack of training, lack of knowledge, also very critical aspect. We have a huge workforce of providers who aren't trained at all in psychedelic-assisted therapy. And also there are legal and ethical concerns that providers are navigating and that we are still navigating in the scientific community as well. And then in terms of implementation, we have to assess these beliefs to help us target education focuses. Things like policy development, training programs, how we work with providers so that they can support safe, ethical, and effective integration, and to be able to provide psychedelic-assisted therapy in their clinical practice. So all of these are important reasons why we must assess attitudes and beliefs. And so I want to share with you two studies that I've done with my team at the CPDRE, really tapping into this. And the first one was a study of social workers, psychologists, and psychiatrists and their attitudes of psychedelic-assisted therapy. All of the data from this came from 3 different studies that all used the same measure of attitudes and beliefs about psychedelic-assisted therapy, and then I kind of pooled everyone together to run analyses. So we can see here, this was a survey, or it was 3 surveys. It included 856 professionals and their views of psychedelic-assisted therapy, again, from 3 separate studies. One was a study of social workers, one was a study of psychologists, and one was a study of psychiatrists. The key findings that came from this analysis when I compared these different professionals and what they believed about psychedelic-assisted therapy is that there were very significant differences by profession that affected the workforce's readiness for implementation. So psychologists, for instance, rated psychedelic-assisted therapy as more acceptable and reasonable than other groups, while social workers expressed more concerns and were less confident about long-term benefits, and psychiatrists reported more understanding about psychedelics in general, but not necessarily more favorable attitudes. So what does this mean? Well, there are implications here for training and how we would roll out treatment. We know right now, based off of that data, that if we tried to roll out this treatment, there would be lots of hesitancy among lots of professionals for lots of different reasons. And so that means we need education. We need to develop training programs to address things like misconceptions, lack of knowledge, and understanding really across our disciplines. And these are barriers to treatment implementation. Things like logistical concerns are certainly barriers. How are we going to integrate an 8-hour psychedelic session into our medical model that we have right now of you get 15 to 30 minutes and I need to move on to the next person? There are system issues. What is our insurance system infrastructure going to do? Are they going to support and pay for these treatments? Are they not going to? Are they only going to pay for some of it? That infrastructure has we have a lot of concerns around that. And of course, there's stigma and outdated drug policy perceptions that impact whether or not our workforce is going to be ready and willing to kind of adopt these treatments into their practice. I also want to talk to you about this other study that my team and I did, looking at social workers' attitudes and beliefs about MDMA-assisted therapy, specifically for adolescents. We know that adolescents are also in the midst of this crisis. And so this is also coming too, right? At some point, we're going to start clinical trials for adolescents. But if we're already worried about what are professionals' beliefs about adult psychedelic-assisted therapy, we have even more hurdles to overcome when it comes to adolescent psychedelic-assisted therapy. So this was a study that we conducted. We included 222 social workers, and it was an interesting study design because we used vignettes, little stories. And there were 2 different stories that our 222 social workers were randomized to. So they only got one, and half of them received a story about an adolescent and their parent who was interested in enrolling in an MDMA-assisted clinical trial for PTSD. And then the other half received a story about an adolescent and their parent interested in a new SSRI that was developed, assisted therapy for adolescent PTSD. And when we compared those 2 groups, we found some interesting things, probably not surprising to anybody, but those in the SSRI assisted therapy group rated significantly higher in acceptability, appropriateness, and feasibility, right? So they thought, oh yeah, SSRI treatments are acceptable, appropriate, and feasible. For those in the MDMA assisted therapy group, their scores were related to higher perceived risk and psychedelic stigma. So what we see here is that in addition, there's also greater psychedelic, when individuals and our social workers reported more psychedelic knowledge, it was correlated with lower stigma and perceived risk. So knowledge seems to be the antidote here, right? When we can provide people with education and knowledge, including our providers, it combats the stigma that we've been fed for decades about how dangerous and how risky these substances are. So again, implications. Stigma and knowledge, there are gaps here. So stigmatizing beliefs and limited psychedelic knowledge might hinder clinical acceptance of MDMA-assisted therapy, specifically for adolescents. And so therefore, what we need to do is we need to train our workforce. Social workers expressed a lot of interest in wanting to learn about psychedelic-assisted therapy, but they're kind of like, where do I go to get that? Because it doesn't really exist. They want to know what benefits psychedelic-assisted therapy has. They also want to know the balanced risks and also the clinical applications. So in terms of future directions, for social workers specifically, we must again develop these targeted education training programs, include social workers in developing these training programs and also implementation, and also address the stigma to improve openness and these emerging therapies. So let's just say for a minute and that we can imagine that we address all of these barriers among clinicians' beliefs. What can we anticipate for the future of mental health care in the US with psychedelic-assisted therapy as an approved treatment? What can we anticipate will change? Psychedelic-assisted therapy has the potential to reshape the mental health care landscape, and we should anticipate significant transformations as psychedelic-assisted therapy becomes more widely available. So this is going to, of course, include new treatment modalities, reshape professional roles, change our clinical environments, and broaden the therapeutic paradigm. So let's talk a little bit more about those things. So first, expanded treatment options. Really, what we're talking about is moving away from symptom management. Psychedelic-assisted therapy emphasizes deep psychological healing and personal insight. That's moving beyond what we typically do right now in mental health care, which is symptom management. It also includes personalized care. We do that to some extent already, but I believe that psychedelic-assisted therapy can deepen that. Treatments like psychedelic-assisted therapy are expected to become more tailored, integrate pharmacological, psychological, and spiritual dimensions in ways that we're not typically used to in Western medicine. In addition, professional roles will evolve. So therapists will be seen as guides. So professionals will take on roles that are known as guides in other settings, supporting patients through preparation, dosing, and integration. Not being the holder of knowledge or the holder of power, but being somebody who works alongside them. Interdisciplinary collaboration, teams will include psychiatrists, psychologists, social workers, nurses, so on and so forth, all contributing their unique and specialized expertise. And new certifications and trainings are going to come on board, hopefully relatively soon, so we can start training that workforce that so desperately needs it. And that will include specialized training for psychedelic-assisted therapy and altered states of consciousness that will become essential for this type of work. Our clinical spaces, those will transform as well. It'll be redesigning our clinical rooms. So our clinical spaces will shift from these kind of sterile, medicalized settings to something that's more calming, holistic, peaceful, homey, to support introspection and emotional safety. Using more sensory elements. Music is a huge part of our treatments currently, and I imagine that we'll probably start integrating other sensory elements like tactile elements or lighting or something else that could enhance the therapeutic experience. And of course, longer sessions. Really depending on the substance, sessions could last quite a while, including 6 to 8 hours, really requiring this overhaul and huge change in our scheduling models and how we use our space. And then in terms of ethical and regulatory evolution, new ethical frameworks are already starting to be developed to include the nuances of how to navigate this type of treatment. This includes updating informed consent procedures for these vulnerable altered states that people will be entering into, cultural sensitivity, trauma-informed care practices, all of these things will be central to this work. And then, of course, the policy and insurance changes. So as we move towards approval, how is insurance coverage going to work? What are our regulatory guidelines going to be? And all of these things are going to need to be adapted to accommodate these treatments. So while there is so much here to be excited and optimistic about, I also want to leave you with a note of caution. And perhaps this might be the most important thing to take away, which is we must consider that culture is hard to change and will likely remain stagnant, as it typically does. And if it remains the same and stagnant, it's going to create the same conditions for mental health conditions to remain. So if that's the case, then psychedelic-assisted therapy runs the real risk of just becoming another medicine to add to the medicine repertoire, right? Just another thing that we can do But yet we're sending people into the same toxic environment that they came from, where we overwork people, we underpay them, we give them medicines and tell them that it's their fault that they're struggling. We just take everything from a non-collectivistic standpoint, right? Where we're not relying on each other like we used to. We're not connected with each other like we used to. Adolescents are spending all of their time on social media. And so they're not having those same meaningful connections where you can rely on one another in a way that can be supportive and helpful and healing. And because of those things, we have a cultural problem as well. And we need to be thoughtful of the context in which we're all existing, the ocean in which we are swimming, so that we can change things at that level too. Because if we don't change things at that level, psychedelics will not be the catalyst that we all want it to be in changing the way that we move forward and how our healthcare system works for us. So my closing question to you is, how might your generation of practitioners help ensure that this moment becomes not just a psychedelic renaissance, but a revolution in care? So I want to thank you for attending this talk. And also feel free to reach out if you have any questions. I want to thank the CPDRE team. They are awesome. If you have any questions or curious about the work that we're doing, please feel free to scan the QR code. It'll take you right to our website. And I think we have maybe about 10 minutes or so for some questions if you have any.
Thank you, Dr. Armstrong. We do indeed have a couple questions. And if anyone thinks of any questions during this time, feel free to also include those in the Q&A function. We'll get to those in a moment. My first question to you, if the future of PAT becomes a reality that incorporates transformations in clinical spaces and models, do you think that this would also impact clinical spaces for cases that, or patients that do not choose the route of PAT?
I think certainly it has the real likelihood of that. You know, if we are altering the way that we're thinking about mental health care to be able to include treatments like psychedelic-assisted therapies, then we're essentially changing a lot of the structures that would include other therapeutic interventions as well. And so if we're thinking about, I mean, one example that comes to mind for me is kind of these, how does the sensory experience change? Are we thinking about how could we include music in a more traditional therapeutic experience? Could we include something that's more tactile? Could we include other aspects? Does the therapeutic day have to be, or session have to be 45 to 50 minutes, or can it look different? So I think it opens up other ways for us to think about what mental health treatment looks like that's not confined to this box that has been largely prescribed to us by medicalized insurance policies and practices. So if we're saying, well, if you can do it for psychedelic assisted therapy, perhaps there's opportunity for us to be flexible in our thinking about other CBT interventions, or when I go see my psychiatrist, or X, Y, or Z. I also think it makes a huge difference for emergency room interactions, right? If our workforce and nursing staff and emergency department personnel are informed about what acute psychedelic experience looks like, they can show up for that person in a different way that is likely going to be, I would say, less potentially harmful than it has the potential for right now. I think there are lots of great mental emergency responders and first responders out there who can show up in a way that's helpful, but I think a lot of our emergency responders, first line responders, don't know what to do with that kind of thing. So I think that even if psychedelic assisted therapy as an intervention is not what somebody seeks, it has the potential to reshape the landscape that could then impact in a lot of positive ways what our mental health infrastructure ends up looking like and being.
Well, thank you. The consideration of other spaces outside of therapy, that's really thoughtful, like emergency departments. My next question for you. In modern healthcare, patients often experience care as fragmented with poor communication between specialties. Considering how PAT places a patient in a particularly sensitive and vulnerable position, how do you envision or perhaps advise a multidisciplinary team to communicate with one another to ensure the patient receives the best care?
I think that's a wonderful question because there has been a push for a while, right, to make teams more interdisciplinary in nature, right? So that you have your therapist, you have your primary care physician, maybe a psychiatrist. But I think the difference in what's happening now and what could happen is that the treatment is not centralized in location to the participant or the patient, right? So the patient has to jump around to all of these different clinical settings. They also have to often be the person who's doing all of the communication between the providers. There's opportunity, right, for providers to talk to one another, but as someone who's been a provider, it's not efficient, it doesn't work great. What I think is unique and potentially really helpful about psychedelic assisted therapy and how it can enhance communication and treatment is that the patient shows up in the clinic room, and then the treatment team shows up around them, right? Everyone's going to the same space. Everyone's going really largely at or around the same time. And there's a centralized kind of team effort of showing up to have those communications with each other at the same time, where we're reducing a lot of barriers. We're not putting it back on the patient to say, you need to be the one to communicate this to your treatment team. The treatment team is there having these conversations. I think that really enhances safety. Right now, nobody's in the room alone with a participant. A lot of times there's video recording happening. So I think when we have more people on the scene, more people saying, we're holding ourselves to a high ethical standard, which we're still getting to in terms of like, what are ethical standards in psychedelic assisted therapy? Let's really hone in on those. We're getting there. I think we have some really clear trajectories, but when we all have that framework and there's multiple people involved, we're increasing communication, we're increasing safety, and we're creating a higher likelihood of successful outcomes because everybody's showing up truly for that person at that time in that space.
Thank you. Does anyone have any other questions? Andrea, do you have any questions?
Actually, we have another question. It came up in the chat if you want to go ahead.
Yep. So the question reads, how much do you think provider perspectives towards PAT could be based on their societal or cultural background?
So much so. Very, very much so. That was one of the biggest things that we saw in the research that we were doing, which is there's just so much stigma that even our clinicians carry, in professions where it might feel like, oh, well, you would think that they wouldn't carry that stigma, but they do, and that's because we've all kind of swam around in these waters of of being told that these are dangerous, not helpful substances that are going to scramble your brain and make you psychotic. And because we've been fed that narrative for decades and decades and decades, even our mental health professionals, there is belief behind it. And even when we can challenge our own belief, right, and say, yeah, but the data doesn't say it, the emotional discomfort is still there. And that emotional discomfort as a professional can be a barrier towards moving toward a place of either, more education or attending a training or becoming involved. And I would say that's even more the case when we're talking about youth and adolescents. I can't tell you how many conversations that I've had with very smart, very intelligent professionals in social work, nursing, psychiatry, psychology, where they're very taken aback by the idea that we might consider using a psychedelic to treat a mental health condition in adolescence. But what's interesting is we have not a lot of concerns about giving adolescents things like antipsychotics for long periods of time. We know that there are negative impacts for long-term stimulant use to treat ADHD. Absolutely. But that's widely acceptable in pediatric psychiatry and psychology. And so it's kind of like, how do we flip the script a little bit? How do we continue to provide education? And I think a lot of that has to do with being open, right? As the scientific community, to be open to having those conversations with individuals, understanding that it's coming from a place of having swam in the same ocean of really misinformation for their entire professional career, including when they were educated. The textbooks said these things. So there are real reasons why our professionals believe the things they believe. And so if we want to combat that, we got to show up in there with them, and be open to hearing their conversations and their concerns. That way we can all kind of move forward together.
Great, thank you.
Thank you so much for your insights and your really interesting discussion, especially in this last question. I think it will inspire lots of the participants and the audience of this Congress. So thank you so much for sharing your wisdom.
Thank you for having me. It's been a real pleasure to be here, and I appreciate the wonderful, insightful, and thoughtful questions.
Yes, thank you.
Thank you.